The ATOMIC trial just flipped the script on adjuvant therapy for stage 3 MSI-High colon cancer. Plus, breakwater data for BRAF V600E metastatic disease. And why exercise is now standard adjunctive care. Join Dr. Jason Zell of University of California of Irvine as he delivers the most up-to-date colon cancer data for MOASC 2026. In 3, 2, 1. How will the ATOMIC trial results change adjuvant therapy for stage 3 MSI-High colon cancer?
Today at the MOASC Annual Meeting, we discussed the ATOMIC trial in context of all other trials using immunotherapy for colorectal cancer. The real contribution of the ATOMIC trial is to show that, yes, indeed, there is definitely an advantage, a nearly 10% improvement in survival after immunotherapy in combination with chemotherapy, followed by immunotherapy alone, 6 months of each. That's a breakthrough finding. The trial took so long to accrue, however, that practice trends have changed. And so really understanding this in the context of the NICHE trial, where we treat patients before surgery with immune checkpoint inhibition, does throw a wrench into how we interpret the data. So I think for now we can say, and until the paper is published, in the postoperative setting for microsatellite unstable or unstable tumors, MMR deficient tumors, at that point when they come into your office, the recommendation is going to be chemotherapy with immune checkpoint addition followed by immunotherapy. If they come in before, most of us investigators prefer the neoadjuvant or upfront nivo ipilimumab 28-day course of treatment prior to surgical resection. And what we do after that is still to be determined.
For BRAF V600E metastatic colorectal cancer, when should the breakwater regimen be preferred over standard chemotherapy?
Today we discussed the breakwater trial, not only the primary analyses of breakwater presented at ASCO in June of last year, but also the follow-up with FOLFIRI as a backbone with Encorafenib Cetuximab was presented in January at ASCO GI Cancer Symposium in San Francisco. So really, these are first-line options for metastatic patients with BRAF V600E mutation. They should not be treated with chemotherapy alone. In fact, from Breakwater 1, we learned that the no chemo arm with just Encorafenib Cetuximab performed better than the chemotherapy patients. But even better than that was the outcome among the chemo, FOLFOX plus EC, or FOLFIRI, which was the real contribution of cohort 3 of this study to show that you can use a different chemo backbone and there were very high observed response rates. So that's really the contribution of this study.
What key takeaways from the challenge trial should oncologists share with stage 3 colorectal cancer survivors?
I think the challenge study, which is a trial of structured exercise program in stage 3 and 2 colon cancer patients that receive chemotherapy, is practice changing. It should be standard recommendation for all patients at the end of chemotherapy with colon cancer. The other thing I think it brings into focus, which is a little more subtle, is a renewed interest in post-adjuvant strategies. This is the first trial, the challenge study. I'm very proud and honored to be part and lead SOA20 PACES, which is a clinical trial run through the cooperative groups looking at eflornithine sulindac versus placebos in the post-adjuvant setting. Each of these trials are designed to see if we can improve standard of care. So the challenge is the first of these long accruing survivorship type of studies, and we hope to see more, including the outcome of PACES this year.
How are you incorporating MSI-High and BRAF testing into first-line metastatic colorectal cancer decision-making?
It's an excellent question. So currently, for metastatic colorectal cancer patients, we do complete genomic sequencing on all patients. Even our in-house panel, which is a limited genetic panel, includes BRAF and microsatellite testing because it's essential. You cannot initiate treatment before initiating first-line therapy. There is a famous cancer center in the United States that says, where you're treated first makes all the difference, and it is true, right? This may result in a slight delay in some cases. It can take 2-3 weeks to get these results back, but they are important drivers of the correct treatment decisions, not only for improved survival and progression-free survival, but also for better tolerability. So it's worth the wait it takes to get those biomarker testing done. For that reason, it is standard for us on every patient to get a panel immediately after the time of resection.
Looking ahead, what role do you see for structured exercise programs as standard adjunctive therapy in GI oncology?
I would say as of today, it's absolutely standard for colorectal cancer patients to be given recommendations for a structured exercise program as I try to incorporate into my practice. Now, what do we do about other diseases? I think that's where it's at. There's often times where we want the level 1 evidence, which is the highest level of evidence from a randomized controlled clinical trial. We have it for colon cancer, but you know what? Before we had that in 2007, we had a ton of observational data that showed us through these large cohort studies that exercise was important. And so we are not surprised by the results. By the same token, there are studies in breast cancer and others that suggest that exercise is also important in the survivorship setting. So until we have level 1 evidence from clinical trials, it's still a safe recommendation with likelihood of benefit. So I think you're going to see a lot more development in the clinical trial setting and also just in practice advocating the unforeseen benefits of the structured exercise program among cancer survivors. We first saw the data from the COMMIT study at ASCO GI in January of this year. This is a randomized controlled trial of atezolizumab with bevacizumab, FOLFOX versus atezolizumab alone. So a combination, 3 different type of agents, actually 4 drugs in that combination versus single agent atezolizumab. The trial is important because BRAF mutant patient, it's a rare population, very hard to accrue to that type of trial, and there's only 80 patients involved in the study. The study findings met their primary endpoint with progression-free survival, more than a 56% decrease in progression among the intervention arm versus single agent atezolizumab. However, in unplanned analyses, the overall survival is identical. Now, the study was not powered to look at overall survival, but the investigators reported that. And in light of the fact that the adverse event rate was so high for the combination arm, with 4 deaths versus 1 related to treatment, and much higher toxicities, it's hard to get enthusiastic about the benefits on progression-free survival in looking at the overall picture. So I think for this one, if anything, the take-home message might be the other way around. Atezolizumab resulted in equivalent overall survival to this combination arm with far less toxicity, and perhaps there's a role for that. But we really need to tease out which patients would benefit from a more intensified regimen regarding the combination arm.
If you like this video, you may also like the suggested video, Scott Kopet's, MD, explanation of the BREAKWATER Phase 3 data. In the description, you will find a link to a web post companion for this video on oncologytube.com. Thank you for watching.